Anticholinergic or parasympathetic bronchodilators. This information is taken from Rau, Respiratory Care Pharmacology, Chapter 7. A key point to remember is that anticholinergic agents given by inhalation are a second class of bronchodilating agents, a backdoor, so to speak, that block bronchoconstriction. Anticholinergic agents, also known as muscarinic antagonists, are often separated into both short and long-acting. Short-acting are known as SAMAs, S-A-M-A-S. Long-acting are known as LAMAs, L-A-M-A-S. Ipratropium bromide and tiotropium bromide may be indicated as bronchodilators for the maintenance treatment of COPD. Ipratropium bromide may also be used in some individuals with asthma. Tiotropium bromide has recently been approved as an add-on treatment in the control of persistent asthma for patients as young as 6 years old. A combination of an anticholinergic and a beta agonist, such as Combivent, ipratropium, and albuterol, may be indicated for patients who receive maintenance treatment for COPD and require additional bronchodilation for relief of airflow obstruction. Ipratropium is commonly used in addition to beta agonists in severe asthma, especially in bronchoconstriction that does not respond well to beta agonist therapy. They are also used as a nasal spray. A nasal spray formulation is indicated for the symptomatic relief of allergic and non-allergenic perennial rhinitis and the common cold. Let's talk about specific anticholinergic agents. Anticholinergic agents are available by themselves like Atrovent or ipratropium bromide. It's available as both a metered-dose inhaler and as solution. They're also available in combinations such as ipratropium bromide and albuterol, commonly known as Combivent Duaneb or Combivent Respiratory. Aclidium bromide is available as Tudorsa Praser. Tiotropium bromide is available as Spiriva and is quite common. It's a once a day given for COPD. Umedaclidium bromide is also known as Incrusa ellipta, and metaclidium bromide in combination with vilanterol is known as Anoro ellipta. Let's talk about ipratropium bromide or Atrovent first. It's available in a metered dose inhaler, 17 micrograms per puff, and 2 puffs 4 times a day, or 2 puffs every 8 hours. It's also available as a small volume nebulizer solution in a 0.2% solution or 0.5 milligram QID. It's available as well as a nasal spray for those of us that have rhinitis and rhinorrhea. It helps to dry the nasal passages and reduce swelling. It's approved for the maintenance treatment of airflow obstruction in COPD. And also, you should know that it is a more advanced form of atropine and doesn't have nearly the side effects because it doesn't cross fat barriers or fat membranes. Distribution is limited to the lung when inhaled. This is what a Combivent inhaler would look like. You can tell the orange and green on the packaging are quite different than some of the other solutions. Available in combination with albuterol and quite commonly used for treating stable COPD. Combivent is 18 micrograms of ipratropium bromide, 90 micrograms of albuterol per puff with 2 puffs 4 times a day. Duodenum, also commonly used in the treatment of COPD, comes in a 0.5 milligram ipratropium bromide and 2.5 milligram albuterol solution for nebulization. The Respiratory is an easy-to-push alternative for people that have trouble with arthritis. So Combivent Respiratory gives 20 micrograms of ipratropium and 100 micrograms of albuterol per puff 4 times a day. Glycopyrrolate is used IV. It's a quaternary ammonium derivative of atropine, and it's used IV to reverse neuromuscular blockade. Currently, it isn't approved for inhalation, but we'll see what the future holds. Let's talk a little bit about Spiriva. Spiriva is a M1 and M2 selective antimuscarinic. It comes in a dry powdered inhaler, 18 micrograms per inhalation, and the great part about Spiriva is that you only have to take it once a day, making it easy for people to remember and easy for people to use. The one bad thing about it is it's a dry powdered inhaler. It takes a lot of breath to suck in on that, a lot of flow. And so some of our more elderly COPD patients find it hard to take a DPI. Increase-ellipta also comes in a once-a-day DPI form, and it's 62.5 micrograms per inhalation. A combination drug, Anora-ellipta, is more commonly used. It is also umeclidine bromide and vilantrol. It is, again, a puff once daily and quite easy to take, other than the fact it's a DPI. Let's talk a little bit about Tudorsa-Pressair. Tudorsa-Pressair is approved for maintenance treatment in COPD. It's available as a DPI with 400 micrograms inhalation, 1 inhalation twice a day. It's easy to push and easier to activate. It's a potent agonist for all the muscarinic receptors, and it has very low and transient systemic side effects. So not as many side effects for this particular drug. So I want to talk a little bit about the chemical structure of atropine and scopolamine. Atropine and scopolamine are a belladonna derivative. Did you know that? Yes, belladonna, the poisonous plant. It's quite beautiful, but quite poisonous. It can stop your heart, and it was used back in the day of kings and queens for heart problems and as a poison. Interesting that atropine is a derivative of it. Atropine, including atropine sulfate and scopolamine, are tertiary ammonium compounds. They differ from each other only by an oxygen atom bridging the carbon-6 and carbon-7 positions. However, our newer drugs like Atrovent, which are a derivative of atropine, are quaternary ammonium derivatives of atropine, including atropine, ipratropium, and tiotropium. Another quaternary atropine derivative, which has been administered experimentally as a bronchodilator by aerosol, is glycopyrrolate, however, or Robinol. Right now, it's used IV or GI in the GI tract to dry up secretions prior to surgery, or if in the case of a death rattle, or in the case of someone with severe secretions and a swallowing disorder. Tertiary ammonium forms such as atropine sulfate or scopolamine are easily absorbed in the bloodstream. They can distribute themselves throughout the body and cause a lot of side effects. Also, they cross the blood-brain barrier. And this isn't the case with the quaternary ammonium forms, like ipium and tiotropium and glycopyrrolate. These are fully ionized and poorly absorbed into the bloodstream or the central nervous system. So much less systemic side effects are seen with the aerosolization of these tertiary ammonium compounds. Let's talk about some of the side effects that atropine has. Some of the side effects that atropine has are in the respiratory tract: bronchodilation and decreased mucociliary clearance. It also blocks hypersecretion. In the central nervous system, there can be altered CNS function depending on the dose. The higher the dose, the more likely to affect the central nervous system. In the eyes, mydriasis and increased interocular pressure can be seen. In the heart, you can have minor slowing of the heart for a small dose or increased heart rate at a larger dose of atropine. In the gastrointestinal system, it causes dry mouth, dysphagia, and can slow motility. And in the urinary system, it can cause urinary retention. Now let's compare this to the quaternary ammonium compounds like Atrovent. Quaternary ammonium compounds like Atrovent, when inhaled, cause bronchodilation but have little or no change in mucociliary clearance. They can also block hypersecretions in the nasal passages, and that's why they're a great nasal spray. There's no effect to the central nervous system, and there's no effect to the eyes unless touched by the hands. We really try to warn our patients to wash their hands after using Atrovent. There's no cardiac side effects. They can cause a dry mouth, and there's usually no effect to the urinary tract. The side effects are localized to the site of the drug exposure, like dry mouth in the mouth from a metered dose or dry powder inhaler, and bronchodilation, which is what we want in the respiratory tract, from blockage of bronchoconstriction from the muscarinic effector sites. So let's talk a little bit about how these drugs work. The parasympathetic innervation starts at the hilum of the lung. These fibers derive from the vagus and travel along the airways. Parasympathetic postganglionic fibers terminate at or near the airway epithelium, submucosal glands, and smooth muscle. And we think the mast cells, but they're still looking into that. Parasympathetic innervation and muscarinic receptors are concentrated in the larger, bigger airways, although they are also present from the trachea all the way down to the respiratory bronchioles. In a normal airway, a basal level of bronchomotor tone is caused by parasympathetic activity. The basal level of tone can be abolished by anti-muscarinic agents such as atropine or Atrovent, indicating that it is mediated by the ACH, acetylcholine. Administration of parasympathomimetics or cholinergic agents such as methacholine, which is used in bronchial provocation testing, can intensify this bronchial tone, causing bronchoconstriction to the point in healthy subjects and more so in patients with asthma. In fact, they don't always use methacholine because it has such a strong mechanism of action. Cholinergic stimulation. An anticholinergic bronchodilator blocks these effects, and how well it blocks the effects depends on the degree of bronchoconstriction that's present. So let's look at an overview of how this happens. Here's a parasympathetic nerve. Here's the preganglionic fiber, the ganglion junction here, and the postganglionic fiber. Acetylcholine comes in, and a parasympatholytic blocks that acetylcholine from starting the bronchoconstriction in the airway. A portion of the bronchoconstriction seen in COPD may be caused by a mechanism of vagally mediated reflex innervation of the airway smooth muscle. Irritants such as aerosol, cold air, high airflow rates, smoke, fumes, and histamine cause a histamine release. The afferent impulse to the CNS causes a reflex cholinergic efferent impulse, and that constricts the airway and smooth muscle, causing mucus and cough. This can be blocked by competitive inhibitors of acetylcholine, like Atrovent or atropine. Let's take a deep dive into this. So, this is the mechanism of vagally mediated reflex. Bronchoconstriction, so irritants, aerosol, cold air, dry air, and other inflammatory mediators, dust, smoke, pollen, come into and affect the airway here. ACH, these affect the airway, they travel down the C fibers and the afferent nerve to the CNS. The CNS sends out a signal here to the submucosal glands with ACH and smooth muscle constriction. See, here's the acetylcholine. It's going to hop into this parking space, and then it will make bronchoconstriction and increased mucosal secretions. However, if we block the ACH from parking in this spot, which is what Atrovent and atropine do, then there's no increased bronchoconstriction and no increased secretions. Let's talk a little bit about the muscarinic receptor subtypes. First is M1. This is at the parasympathetic ganglia. It facilitates neurotransmission and bronchoconstriction. It can also cause increased secretions and increased rhinitis in the nose, so it can cause stuffy and runny nose. The M2 muscarinic receptors inhibit the continued use of acetylcholine. The blockade may enhance acetylcholine release, counteracting bronchodilation. Tiotropium bromide is selective for M1 and M3. Let's look at the M3. This is the smooth airway muscle and submucosal glands. M3 causes bronchoconstriction and causes secretion and rhinitis in the nose. So here is your M1 receptor at the ganglionic synapse, the postganglionic synapse. Here's ACH going over to that M1 receptor site. Here is a M2 receptor on the postganglionic nerve, and here is an M3 receptor for submucosal glands and for smooth muscle. Here's the airway epithelium here with the M3 receptor. An anticholinergic drug blocks the ACH from parking in this spot and causing the reaction. Same as here at the M3 receptors. Like tiotropium bromide, it comes along and parks in this spot, and the acetylcholine can't get in there and start the reaction to constrict muscles and increase secretions. Some of the adverse side effects. There are usually no changes in blood pressure, EKG, or heart rate. With Atrovent, drugs like Atrovent and tiotropium bromide. No worsening of the ventilation, perfusion abnormalities, or VQ mismatch. No tolerance or loss of protection. Some of the side effects though, and dry mouth is the most common. Dry mouth, cough, mydriasis. Eyes should be protected to prevent this. Hand washing usually helps, and not touching the eyes. Small volume nebulizers are known also to cause pharyngitis, dyspnea, flu-like symptoms, bronchitis, and upper respiratory infection, especially at higher doses. So when should we use this? Well, we use this in COPD or chronic obstructive pulmonary disease. Anti-muscarinic agents have been found to be more potent bronchodilators than beta-adrenergic agents in bronchitis and emphysema. And this is likely to be their primary clinical application and what you'll see most often. It's FDA approved specifically for COPD, and tiotropium bromide maintains higher PFT levels than ipratropium bromide. Spiriva has, after a month to 6 weeks of use, usually shows an increase in their FEV1. So let's look at this in an illustration. This compares the effects of ipratropium bromide to metoprolol. On the right here going up, you can see the mean FEV1 change, percentage change, and here are minutes after treatment. If we look at 60 minutes after treatment, there's a 25% change in FEV1 compared to a 15% change for metoprolol. Both are significant, but for chronic COPDers, the effects of ipratropium bromide are much better than those of metoprolol. This study was done in 1986. Let's talk a little bit about its use in asthma. There is no on-label indication for asthma in the United States. However, antimuscarinics are not clearly superior to beta agonists for asthma. They're still being studied. They may be useful in nocturnal asthma, psychogenic asthma, asthmatics being treated for another condition with a beta blocker, and as an alternative to theophylline. They also may be useful in acute or severe episodes not responding to a beta agonist. Combination therapy. A beta adrenergic and anticholinergic agents in COPD are complementary sites of action. The mechanisms of action are separate and complementary. The additive effect or synergistic effect of beta agonists and anticholinergics result in a 30 to 33% increase in FEV1 for combined drugs. When used alone, there's a 25% ipratropium bromide increase in FEV1 and about the same, 27% for albuterol alone. So the two combined result in about 10% more effectiveness. So what sequence should you administer these drugs as an RT? There is no data to support that either drug should be given first. It's not an issue when you use Combivent. They're given at the same time, or Duoneb. A beta agonist may be given first in some cases because there's a more rapid onset, opening up the airway and allowing the ipratropium to get into the larger airways quicker. Remember that ipratropium bromide is distributed in large and small airways, but the biggest effect is seen in the larger airways. What do you assess? What are you going to look for in a patient when you're giving these drugs? Well, you want to assess the effectiveness based on the indication for use. Look at their flow rates, peak flows before and after. Perform your respiratory assessment, listening to breath sounds, auscultating, taking a respiratory rate and heart rate, both pre and post treatment. Be sure to assess the heart rate and the patient's subjective reaction. I feel better, or I feel worse. Anticholinergic bronchodilator therapy can also be monitored with lab tests like arterial blood gases and an SpO2 and annual PFTs. Instructions and verification of the correct use of the delivery device, whether it's a metered dose inhaler with a spacer or a Respimat, is important to make sure that your patients are taking the drugs appropriately and to see if they maybe need to be switched. If they can't push a metered dose inhaler anymore due to arthritis, maybe they need to be switched to a small volume nebulizer, etc. For long-acting drugs, ongoing lung function or PFTs are needed over time. It's important to ask about nocturnal symptoms, exacerbations and hospitalizations, and absences from work or school. This is the end of our program. Thank you for your time and attention, and I hope you learned a little bit about anticholinergic agents.